Okay, yes, so I'm going to talk about DiPEP, which is a study that we undertook funded by the NIHR, looking at diagnosis of pulmonary embolism in pregnancy. Clearly an important topic and area where my world of emergency medicine, I'm sure, overlaps with your worlds of thrombosis and obstetrics. So just the usual disclaimer that I always have to kick off these presentations with. This was funded by the NIHR Health Technology Assessment Programme. The views I'm going to express are those of myself and the trial team, rather than the Department of Health or the NHS or the NIHR. And of course, I must thank the very large team we had to deliver this trial, and in particular, Francesca Cullinane from Thrombosis UK, who provided patient representation to our study. So, I mean, this is the obvious first slide in which I tell you what you already know, which is that PE in pregnancy and postpartum is the leading direct cause of death. Symptoms suggestive of PA are common. Women who are pregnant often suffer from chest pain, shortness of breath. So we end up investigating a lot of women with a low diagnostic yield. Royal College of Obstetrics and Gynaecology and American Thoracic Society guidelines suggest that all women with suspected PE should have a scan, whereas the European Society for Cardiology guidance suggests a potential role for D-dimer in selecting women. So there is some uncertainty and disagreement there. Now, of course, in the non-pregnant population with suspected PE, we make great use of clinical decision rules and D-dimer to select higher-risk people for scanning and allow lower-risk people to be discharged without further investigation. But these clinical decision rules have not been validated in this population. There are concerns about the poor specificity of D-dimer in the pregnant population because D-dimer goes up during pregnancy. So these tests are not currently used, certainly in the UK, to select women for investigation. So this was our research question. Could a clinical decision rule or D-dimer be used to select women for imaging? If not D-dimer, then there are other biomarkers that might be useful for selecting women. And that's a much less researched area. So these were our objectives. In pregnant and postpartum women presenting with suspected PE, what clinical features are associated with the diagnosis of PE? So what clinical features might be useful in our assessment? What's the diagnostic accuracy of existing clinical decision rules? And included in that, I also mean clinical decision rules that we developed specifically for this project by using expert consensus. What's the diagnostic accuracy of D-dimer, Ecg and Chest X-Ray, the investigations that we commonly use or have available currently to us to investigate PE in pregnancy? And what's the accuracy of alternative biomarkers other than D-dimer? Now, ideally, the study design we'd like to use is the big prospective cohort design. So we get a big group of women with suspected PE in pregnancy or postpartum. We do all the tests that we're interested in, and then we do definitive testing with scans to find out whether or not they have a PE. The problem with that design is the low incidence of PE in pregnancy. We estimated before the study that there's about one case of PE in pregnancy per hospital per year in the UK. So that would mean we'd have to collect data on an awful lot of patients to get the sort of numbers we need, because the number of women with PE is an important determinant of whether we can use the information from this study. And really, we need about 100 women with PE in pregnancy before we can make precise estimates of sensitivity, which will allow us to reliably rule out PE, which is what we want to do with decision rules and D-dimer. So instead of doing a huge, many years, many hospitals prospective study, which would have cost more than the Health Technology Assessment Programme was willing to pay, we suggested a design, which they accepted, of a prospective cohort study, but augmented with additional cases, so additional women who are retrospectively identified with PE that we could also collect data on. Now, clearly, retrospectively identifying, we can't collect biomarker data, so we had to think of a way of increasing the number of biomarkers, the number of women with PE in the biomarker study. Well, we didn't increase the number with PE. We actually also went for women with DVT, because we postulated that biomarkers, the way they work is detecting clot, so clot in the legs was a good surrogate for clot in the lungs. You can argue with that, and you may well do. So, the participants in data collection, we collected data over 18 months from those dates. That's our prospective cohort, 324 women with suspected PE presenting to 11 prospectively recruiting sites over that time. And over the same time period, we used the UCOS, the UK Obstetrics Surveillance System, to also identify any women in their participating hospitals who was diagnosed with a PE. And there were 198 women diagnosed with PE across UCOS, across the whole of the UK during those 18 months. We collected standardised data to try and minimise bias due to our different sources of data we were getting here. And we also identified 18 women with diagnosed DVT across our participating hospitals who were prospectively identified, and we managed to take blood samples from them for the biomarker study. The clinical decision rules we wanted to use. Well, at the bottom here, we've got the recognised existing rules, but we had to modify them so they were suitable for use in pregnancy and postpartum, because clearly age cut-offs of 65 are not going to be appropriate there. We had to work out what to do with exogenous estrogen and things like that. So we modified them for pregnancy. And then we got an expert consensus group together, building a Modelphi study to create 3 expert consensus rules. There was one where we thought we'd try and get the balance of sensitivity and specificity. So we weren't missing cases, but we weren't investigating too many. We tried to get the balance right. We did another one where we said, well, let's just make sure we get sensitivity. We push sensitivity as high as we can, forget about specificity. And another one we said, well, let's sacrifice sensitivity at the expense of for gaining specificity. So we had a specific and a sensitive rule. Now, the reference standard diagnosis, you think this is going to be easy, don't you? You think women either have a PE or they don't. But of course, it's a lot less clear than that. So we had to work out a robust way of identifying which women had PE and which ones didn't. So we got 2 independent assessors looking at the imaging results, what treatment they got, and any adverse events up to 30 days to classify them as either having PE or not. And then we decided to have several different analyses. A primary analysis, which we limited to women with conclusive diagnostic imaging. So there was only the women with a conclusive diagnostic imaging or some other conclusive proof, such as PE at surgery or post-mortem. And that was 181 women with PE and 259 without. And then we had secondary analysis, also including women with clinically diagnosed PE. So there are some women with equivocal imaging, and I think even 1 or 2 without imaging, who still got treated for PE and diagnosed PE. And there were a rather bigger group with clinically ruled out PE. So these were women who were recruited into the study because at some point someone decided they needed investigation for PE, but then usually what would happen is a more senior person would come along, review the patient and decided that they didn't need imaging. So they had clinically ruled out PE, they didn't have imaging. And then we also did a further secondary analysis excluding women with subsegmental PE because there's some question about whether they're clinically important or not. I'm only going to present the primary analysis, but just to reassure you, we have done the secondary analysis, it's all written up, and essentially doesn't show a lot of difference from the primary analysis. So you're not going to be missing out on anything by me not presenting that today. So let's start off with the clinical features then. So we looked at a wide range of different clinical features, and the first big headline thing to say is that most of them were not associated with the diagnosis of PE. They were not diagnostically useful. They were just as likely to be present in women with PE as those without PE. So what I've done here is I've presented one where there was a significant difference in the presence of the clinical feature between women with and without PE. And even here there's a few surprises. So first on the varicose veins, well actually the women without PE were more likely to report varicose veins than those with PE. Recent long-haul travel, women without PE were more likely to report that they'd recently been on long-haul travel than women with PE. So that's counterintuitive as well. Now there's various explanations for this. It may be that there's a selection process going on in our cohort here where if you have recently got varicose veins or recently travelled, you're more likely to be referred up to hospital for investigation. Or it may be a recording issue, that because we're collecting data from different sources, they're more likely to be accurately recorded when identified prospectively. But that's a bit confusing. Recent surgery, okay, a bit more reassuring here. So recent surgery is associated with PE. That was mainly caesarean section in the recent surgery. Number of previous pregnancies more than 24 weeks gestation. That's the more previous pregnancies you have, the more likely you are to be in the PE group. Temperature, for every degree centigrade rise in your presenting temperature, you're more likely to have an increased odds of having a PE. And oxygen saturation. The higher your oxygen saturation, the less likely you are to have a PE. And that's actually the strongest predictor of them all, really, oxygen saturation. But just to show you what we're up against here, I hope you can see the dots on this. I've got a pointer, that's good. So these dots, each one of these is a woman. This is the oxygen saturation up to 100% here, 90%, 80%, 70%. These are the ones we excluded from primary analysis. These are the women without PE, and these are the women with PE. So you can see generally the women with PE had lower oxygen saturations, but most of them had a normal oxygen saturation. And there were still a few women without PE that had low oxygen saturation. So you can see, I mean, it's useful, but it's by no means diagnostic. And then if I show you, I'm just going to pick out one of the other physiological variables, but I could show you any one of respiratory rate, heart rate, or blood pressure. This is heart rate. So these are the women who are excluded, the women without PE, the women with PE, 100 beats a minute. And you can see, well, your women without PE, an awful lot of them have got pretty significant tachycardias, as you know, because you get a tachycardia during pregnancy. The women with PE, well, yeah, quite a few of them had tachycardias. Awful lot of them had a normal heart rate and relatively low heart rate. So really no difference in heart rate. So heart rate in our cohort wasn't diagnostically useful, and nor was respiratory rate or blood pressure. So you won't be that surprised to know that if the clinical features aren't that useful, that when we put them together into a clinical decision rule, they're not that useful either. And these are our clinical decision rules. What I've presented here is the area underneath the ROC curve. Now, the best that can be is 1. If it's 0.5, then it's no better than tossing a coin. And usually, for a decent clinical decision rule, we want an area on the Roc curve to be more than 0.8. And these are all well below 0.8. Just one here. You see, this one's the Wells criteria. Now, the Wells criteria, these have got this funny question in it about, is PE the most likely diagnosis? And you kind of think, well, you know, if I could answer that, then I wouldn't need a clinical decision rule, would I? But we had to work out a way of interpreting that. And we looked at it in 2 ways. One was permissive, in which we said, well, any diagnostic word that suggested the possibility of PE was being considered, that will score it there. And then we had a strict interpretation, which is only when they said the most likely diagnosis is PE, did we include it. And actually, when that was included, then actually Wells did perform quite well. But that seems to be saying that if overall you think it's a PE, then it's likely to be a PE. So there are questions about that, about how useful that is. Sensitivity and specificity. These use the typical thresholds that we use for decision making, and for our consensus rules, we set thresholds so we would optimize sensitivity or specificity. Now, first of all, you could say, well, look, the sensitive rule's got good sensitivity. We could use that to rule out PE. Well, yeah, you could, but you'd only be ruling out PE in 3.5% of your cohort. And of course, you could say the same thing about the women with PE. It's only about 4% of them will have a positive negative rule here as well. So really, no, it's not any use. The PERC rule, you're supposed to be able to apply it and say if they've got any of these criteria, it's not a PE. And so that's the threshold we use there. But applying that, about 1/3 of the women would have scored 0 on the PERC rule. So we don't want to be ruling with PE out on the basis of a 0 PERC rule. That would be missing an awful lot of PE. So, is D-dimer any better? Well, first of all, we did have D-dimer collected on some of the patients in the cohort, about 1/3, but that's a selected group. So just bear that caveat in mind. We used so these are hospital samples. First of all, we used the conventional threshold in operation at the hospital. And of course, they're all using different assays, using different thresholds, but we used the one that they used in their hospital. And yeah, it's got the same sort of sensitivity as any other patient group, but the specificity is rubbish, it's useless. And in fact, you're actually more likely, just slightly more likely to have a positive D-dimer if you don't have a PE than if you do. So it's really not any good. We then tried a pregnancy-specific threshold, saying that we'd use a higher threshold later on in pregnancy and postpartum. So that inevitably reduces our sensitivity. It brings our specificity up to a level where you might start thinking it's useful, but of course, we're not going to be willing to miss 1 in 3 women with a PE. And again, this is diagnostically useless. So, Ecg and Chest X-Ray. We're quite strict in what we defined as a PE-related ECG abnormality. So only a few of the women in the cohorts had a PE-related ECG abnormality, and it wasn't predictive at all. However, PE-related chest X-ray abnormalities, so this is where the radiology report said something like atelectasis, query PE, or query infarction or infection, or something, query pulmonary infarction. So they actually sort of specifically mentioned possibility of PE or pulmonary infarction. Well, that was predictive, highly predictive, but only a few women actually had PE-related chest X-ray abnormalities. A larger proportion had other non-specific X-ray abnormalities, and probably the main ones amongst these were, in addition to atelectasis, were consolidation, effusion, cardiomegaly, those sort of things. And they were predictive of PE, which is quite a worthwhile remembering that, particularly if you're tempted to spot a patch of consolidation on a chest X-ray and say, oh, well, that must be the cause of the symptoms, it's an infection, because some of these actually were reported as pneumonia, and they actually turned out to be PE. So I think that's an important finding we should bear in mind. So the biomarkers. So now these are the biomarkers that we collected prospectively from our patients, and then Beverly analysed them in her laboratory. And I'm just going to show you the ROC curve. So this is a plot of how sensitivity on the y-axis here and 1 minus the specificity on the x-axis here vary as you lower the threshold. So as you lower the threshold for positivity, sensitivity goes up, specificity goes down. Now again, a good Roc curve should come right across here. So you're getting good sensitivity and specificity up here that's useful. Whereas you can see this is D-dimer, not completely useless, but you're not really getting a lot of bangs for your bucks here. So, to be able to get decent sensitivity, you're really having to sacrifice specificity. I'll show you in a moment what you get for that. These are a bunch of other biomarkers related to thrombin generation, prothrombin time, APTT, and again you can see they're really flat ROC curves, not very diagnostically useful, with maybe one or two edging up towards starting to be a bit diagnostically useful. And then more curves for other biomarkers, BNP, C-reactive protein, Klaus fibrinogen, MR-pro-ANP, plasmin, antiplasmin, tissue factor, and troponin, all there. And these are getting towards being straight lines, being really diagnostically not useful at all. I've got a caveat I'm going to mention about all of this, but let's just have a look at how this would work if we try to use this in practice. Those are your areas under the ROC curve, all pretty poor. Just the one starting to maybe get a bit useful, thrombin generation lag time, but this was one out of a lot of biomarkers we tested. That might just be it got lucky. And if we said, well, what would happen if we set a threshold that gave us good sensitivity above 95%? Would we get decent enough specificity that we could rule out a decent proportion? Well, not really, with a possible exception that thrombin generation lag time, we might be able to rule out a PE in a quarter of the women. So that's the only one showing any sort of promise. But there are some limitations and caveats about all of this, which I must mention. First of all, just to make it clear, when I'm talking about clinical factors not being predictive, we did not do a study looking at risk factors in pregnancy. All the risk factors that you know of as being risk factors for VTE in pregnancy are still risk factors. It's just when you have a selected group of women being investigated for suspected PE, they are not diagnostically useful. And that's probably because these risk factors, as the second point makes clear here, are probably one of the things that are being used to select women and determine that they have to be investigated in secondary care. You're more likely to get investigated for query PE in secondary care if you have risk factors and things like that. That's my theory. That means that we have to be very careful at extrapolating this to other populations or other settings, out of hospital settings, primary care, community care. This is true in secondary care, but not necessarily primary care. The cases were retrospectively identified, so the clinical features may be less rigorously identified. We try to make it as consistent as possible, but we can't guarantee that. And another important point, most of the blood samples, about 2/3 of them were taken after anticoagulation. This is inevitable, really, because NICE guidance tells us that if you suspect a PE, you need to give anticoagulation before imaging and before diagnostic investigation. But it does cause problems for us doing our research because, of course, anticoagulation messes up a lot of these tests. And that might explain why they were so poor. We analysed the ones that had not received anticoagulation. There was no signal of them performing better, but these were very imprecise estimates because they had very small numbers with clots. So these are our conclusions. Clinical features have little diagnostic value in women with suspected PE in pregnancy in secondary care, important caveat. Clinical decision rules and D-dimer should not be used to select women for imaging. Does that mean you scan everyone? Well, that's tricky because about a fifth of our population didn't get scans, and as far as we can tell, didn't come to any harm. So we can't say definitely everyone has to have a scan, but certainly we should probably carry on what we're doing at the moment. Chest X-ray abnormalities, even if the radiology report says this is infection or something else, still be suspicious of PE. And current biomarkers show little promise, but maybe we need to find a way of evaluating them before people receive anticoagulation. And with that, I'd like to conclude.